Hello, welcome to ANVC's 2022 webinar series. My name is Alicia Richardson, and I'll be moderating today's session titled Finding Reasons to Treat, Strategies to Optimize Delivery of Intravenous Thrombolysis. ANVC is dedicated to the creation of seamless neurovascular care services led by evidence-empowered clinicians that fully support the holistic needs of patients and their families, because stroke patients deserve nothing less. The series has also been endorsed by the Society of Vascular and Interventional Neurology and Mechanical Thrombectomy 2020. For more information about ANVC, please go to our website at www.anvc.org and become a member if you aren't already. A few more housekeeping items before we begin. The session will be recorded and available on the members only section of the ANVC website. The session that's taking place today will not be eligible for CE credit. This is due to a sponsorship agreement with the medical product and service company, which is not permitted under the ACCME standards for integrity and independence in accreditation for continuing education. The speaker's expertise, however, in the field related to this topic is of great value, so ANVC opted to continue without CEU accreditation for this webinar. That being said, participants will receive 1 stroke education hour for the live session only. You must attend the entire session to receive the credit. Please feel free to enter any questions into the chat throughout the presentation. We'll have time at the end of the presentation to address any questions you may have. And without further ado, I'm very proud to introduce our presenter for this webinar, Dr. Anne Alexandrov. Dr. Alexandrov is a professor of neurology and nursing at the University of Tennessee's Health Science Center in Memphis, Tennessee. She is also their chief nurse practitioner on their mobile stroke unit and is the professor and NetSmart program director and also ANVC's current president. Go ahead, Anne, take it away.
Thank you, Alicia. Well, it's my pleasure to talk to you today about finding reasons to treat and strategies to optimize delivery of intravenous thrombolysis. I want to first of all thank Genentech for their sponsorship of ANVC programming. That said, I want to make something clear, and that is that the content that's presented in this webinar is original content, and it's produced by me, not by Genentech, and none of the content, in fact, that was supplied for this came from Genentech. And additionally, I have not received any compensation related to this presentation from Genentech. Now, the focus for this program will be on alteplase tissue plasminogen activator, and I deliberately am excluding discussion of tenecteplase tissue plasminogen activator. Both of these drugs fall into that same TPA category. Alteplase is the only one that's approved in the United States. And of course, there are many sites that are using TNK, but again, I will not be discussing it. And I'd appreciate it if you keep your questions in line with that and just ask questions that relate to alteplase TPA. Now, I thought I would start by just giving you a little bit of background about my intravenous TPA journey, because I started way back in 1986 giving TPA in acute myocardial infarction. And back then we had a trial underway, and actually lots of different trials underway around the world that oftentimes are kind of clumped together as thrombolysis and myocardial infarction trials, or TIMI trials. Some actually had that name. And then in 1991 through 1995, I had the distinction of being asked by my boss at St. Luke's Texas Heart Institute if I would oversee intravenous TPA treatment during that original NINDS RTPA stroke study that was underway to try and get TPA approved for the treatment of acute ischemic stroke. And this was again in Houston, Texas. We were the largest admitting stroke center in Houston and in Texas. And we also had the largest number of TPA treats in the trial for the Houston division. In 1997, after TPA was approved in 1996, and from then through 2005, I actually accepted a faculty appointment as an assistant professor of neurology at the University of Texas at Houston under the leadership of Jim Grotta. And during that time, I had the opportunity to collaborate on creation of stroke centers all around Houston, Texas, with Jim and my local American Heart Association representative, Michelle Heilman, who has since retired. But during that period, we actually created 12 stroke centers between 1997 and 2000. So that's really early, before most of the country was even in the process of thinking about stroke centers. And during that time, we also completed and published the HOPS-2 study that was funded by the American Heart Association, where we saw that you could adequately train paramedics to make an accurate diagnosis of stroke. And then if they went into a stroke center hospital, it resulted in more patients getting TPA treatment. Now, I then went on and completed a physician vascular neurology fellowship in 2001. There were no fellowships for advanced practice nurses at that time, and Jim Grotta felt strongly that I should just be one of his fellows in the vascular neurologist program. I also completed a neurosonology fellowship in 2001 with my now husband, Andrei Alexandrov. And I completed my PhD, which is in physiology and focused on integrated intracranial and systemic hemodynamics, in 2002. We completed and published the clot bus study, which was funded by the National Institutes of Health and published in the New England Journal of Medicine, which was a study where we showed that you could amplify TPA treatment with 2 megahertz transcranial ultrasound. And I'll talk a little bit more about that later. And in 2005 to 2007, gave a lot of IV TPA in Phoenix. Between 2007 and 2014, gave a lot in Birmingham. And from 2014 to present, gave a lot, and still am giving a lot of TPA in Memphis, Tennessee. In fact, during our tenure here, Memphis had achieved recognition as the city with the highest volume TPA treatment per capita in the world. And this year, we'll be kicking off the rescue study, which again is going to look at amplifying TPA with 2 megahertz transcranial ultrasound in patients with large vessel occlusions that arrive at a primary stroke center, are candidates for thrombectomy, but require transfer to a thrombectomy capable center. And I'll talk more about that at the close of my presentation. Here's my 2 TPA inspired mentors, Andre, my husband, and Jim Grotta, who I still affectionately call the boss. Now, just to show you our statistics here at the University of Tennessee Health Science Center, for our stroke team, which is a citywide stroke team, we give about 1,000 IV TPA treatments per year citywide. And our largest comprehensive stroke center, we give about 580 a year, and the rest come from the other centers around town. We do about 350 thrombectomies per year citywide. Our symptomatic intracerebral hemorrhage rates are low. They're consistently less than 2% for IV TPA and less than 3% for thrombectomy. And our mobile stroke unit treatment rate is about 33% per year of all ischemic stroke patients that we diagnose and transfer. And we only have a 0 to 1% SICH rate in those patients. We've given TPA by an intraosseous route, and we had in one patient, and 31.5% of our patients receive TPA within the first 60 minutes of symptom onset. Now, with that as a backdrop, one could say that the United States should be the leading provider of TPA in the world, because we were the first country to approve intravenous alteplase for treatment in acute ischemic stroke. And you'll recall that was in 1996 that the United States Food and Drug Administration, or FDA, gave that approval. And the original purpose for creating stroke centers was to treat patients with TPA. That actually came out in a 1997 statement from the NINDS investigators from the original TPA study, that a stroke center's job was to give TPA to any patient that meets criteria for it. And when you think about it, right now we have 3,500 hospitals that are classified as stroke centers around the country. So we should be giving a boatload of this stuff. However, TPA treatment rates are significantly lower in the United States compared to foreign countries that have had approval for a shorter period of time. And this continues to be a problem. In fact, in thrombectomy capable and comprehensive stroke centers, there are even interventionalists that are saying, you don't need to give TPA to my patient. Now, treatment criteria, when we think about it, and let's go back to what the United States FDA looks at, and then we'll look at some of the worldwide treatment criteria, because ANVC does have a good deal of membership outside this country and other English-speaking countries like Australia, New Zealand, and the United Kingdom and Canada. But when we think about treatment criteria, obviously alteplase is indicated for the treatment of acute ischemic stroke, and we want to exclude hemorrhage as the primary cause of stroke signs and symptoms. And we do that with a non-contrast CT, because CT scans are exquisitely sensitive to the presence of hemorrhage. Now, we also want to initiate treatment as soon as possible. If we look at the US FDA guidance, it says within 3 hours of symptom onset, or if we look at the US guidelines and we look worldwide at the standard of care, it's within 4.5 hours after symptom onset. Or if you're an advanced stroke program like ours is as a comprehensive stroke center, then when you're using advanced imaging that documents that you've got viable brain in a patient with an unknown time of onset, you should think about treating those patients. So for example, if you're using the wake-up protocols, that's an MRI protocol looking for a DWI flare mismatch. DWI will become positive with ischemia very quickly after the onset of stroke, whereas flare can take many hours to become positive. Generally, we're talking about 5+ hours to become positive. And so when we look at a patient that has a positive DWI and a negative flare, that tells us that we're pretty close to being inside that window for TPA at 4.5 hours. And then there's the aspects that can be read as well. The Alberta Stroke Program Early CT score, which is what our program tends to do, although we have also done MRI, DWI flare mismatch at times. Now, let's start first by looking at US TPA contraindications. First of all, any current intracranial hemorrhage. Now, we no longer exclude patients with a history of hemorrhage. So if the patient at the age of 20 had an intracranial hemorrhage from motor vehicular trauma and a traumatic subarachnoid hemorrhage, for example, but now that patient's 60 years old, that patient is indeed a candidate for intravenous TPA. Subarachnoid hemorrhage, kind of the same deal. If there's obviously subarachnoid hemorrhage, you're not going to treat the patient. Any active internal bleeding, especially the type of bleeding that cannot be compressed, that would be a contraindication. Recent or within 3 months intracranial or intraspinal surgery or serious head trauma would be another contraindication. And that's really something that'll probably stay forever on your country's license or label, just because who wants to do that study, right? I don't know of any patients that are going to want to say, sure, you can treat me a week after intraspinal surgery, right? So we'll probably keep that one forever. Presence of intracranial conditions, for example, structural conditions that might increase the risk of bleeding. So the patient has a big brain tumor, especially tumors with Mets, those are very prone to bleeding. This is a patient, obviously, that the symptoms are not caused by stroke, and I would not be treating that patient. But it also includes structural conditions such as vascular malformations or vascular aneurysms in the brain. And then bleeding diathesis, which our guidelines in each country pretty well discuss. And then current severe uncontrolled hypertension, which really in this country is rarely a reason not to treat a patient because we have good drugs these days. Now, let's say that you are from the UK or Australia. Well, things look quite a bit different, as you can see. You've got check marks under things that in the UK, which everything on this list is an additional exclusion according to the license for thrombolysis in the United Kingdom. In Australia, they're a little bit more like us. You'll see that there's a few additional things like significant bleeding disorders or intracranial hemorrhage at any point in the past. But then things like if the patient has a urinary tract or GI hemorrhage, it's a relative contraindication because you can, of course, treat that patient with transfusions if you need to. And it may, in fact, be stable and not even react to an intravenous TPA treatment. And again, they're more test-based, looking at the coagulation findings, whereas the UK is an absolute hard stop. Rapidly resolving symptoms, they tell you to use caution, observe seizure at onset, use caution. And suspicion of endocarditis is another hard stop in Australia, and abnormal glucose, which of course we can very quickly and easily measure and manage, is a relative contraindication. So you can see how things differ worldwide, with the United Kingdom being the most exclusive, if you will, at coming up with contraindications. Now, I want you to remember that because I'm going to show you some data shortly that should surprise you given that point. Now, what I'm really getting at is that many practice sites across the world continue to adhere to contraindications that we used in the original clinical trials that got TPA approvals. And they call these hard stop contraindications at different sites. These are not hard stop contraindications for things that, for example, are on a license for the drug or a label for the drug. They're just identified by individual practitioners that we should never treat these kinds of patients. And it's important to remember that when we come up with exclusions for clinical trials, it's because we certainly, A, don't want to harm anybody, right? And B, it's because we're looking to eliminate things that could confound our ability to find a difference, right? So for example, seizures were part of the original exclusion in the NINDS-RTPA stroke study. And that's because the concern was that if I treat you with TPA and you get better, then how do I know that it wasn't that you were just post-ictal, right? And so you don't want those kind of patients in a clinical trial because you're trying to prove that TPA works. And so that's what you'd call a confounder that you would exclude for that reason. But let's look at some of these things then that kind of ran over from clinical trials that some practice sites absolutely are still hanging on to, even though the label doesn't want you to. Age limitations. ECAS-3 did not enroll patients over the age of 80. And so a lot of people will not treat patients over the age of 80, especially if it's outside the 3-hour window, despite the fact that there's also data that came from other trials that have shown that it's absolutely safe to treat these patients. Now, NIH score limitations, another one. There's certainly data from the ECAS-3 study where they excluded patients with greater than 25 NIH stroke scales. And again, that was done in the ECAS-3 trial because they wanted the trial to be positive. They excluded ultra old people because mortality oftentimes is tied to increased age, and they excluded extremely high NIH stroke scales because those were the most severe strokes, and they wanted to be sure that they had a positive trial. Seizure at onset, I just talked about, was an original exclusion from the NINDS-RTPA stroke study. We can now do CTAs on patients and see if there's an occlusion that might be producing a cortical stroke that has now become a site for seizures. Rapidly improving symptoms was something in the NINDS RTPA stroke study, and you'll notice that the UK still has that as a hard stop. Australia calls it relative. Think about it. Is the patient actually getting better because it's post-ictal or because it's a TIA? But this is no longer an exclusion in the United States for treating a patient with IV TPA. In fact, you are better off to treat that patient than to risk delaying treatment and the patient actually doesn't get all the way better. A history of ICH, this was an exclusion in both studies. By the way, ECAS-3 stands for European Cooperative Acute Stroke Study number 3, which was led by Werner Hake and colleagues across Europe, and was published in 2008. And again, in the US, we no longer hold on to that. A combination of a history of stroke with a diagnosis of diabetes came out of ECAS-3. And again, if we did that in the United States, we wouldn't be treating most of the patients in our hospital. Now, what I want to look at too is the fact that sometimes we decide in our stroke centers to make up inclusions and exclusions to TPI treatment. And I always call this finding reasons not to treat. And that's not your charge as a stroke center. Your charge is to find reasons to treat patients, right? So we completed a cross-sectional study. It was a survey of stroke center hospitals where we asked stroke coordinators in the US, Australia, and the United Kingdom to actually pull their order set and tick off in the little box everything that is an exclusion and an inclusion for intravenous alteplase treatment. So first of all, let's start with the treatment rates that we found nationally for each country. Remember how the UK has got all those exclusions? Well, they are still treating almost 13% of patients. They only got approval to start giving TPA in 2008. They were one of the last countries in the world to get approval so late. And they're already, flying by us, which is a bit concerning, right? But here's the most common made up or non-standard inclusion criteria. NIH stroke scale scores greater than 4 points. And you can see that even here in the US, 35% of stroke coordinators identified that this was on their inclusion checklist for getting TPA. Favorable CTP in patients that are inside the window for treatment. Australia is mad about their CTPs, so it's kind of difficult to convince them otherwise. Most of the rest of the world's pretty much gone away from them. But you can see that they kind of lead the way here, and they will not give a patient TPA even if they're inside the window and they don't like the CTP pattern. In the US, almost 20% of centers were doing CTPs on patients inside the window. Well, what do we know about CTP? It does a great job of excluding patients by being ultra conservative and assuming that tissue are dead. Remember, this is not a metabolic study. It does not go in and tell you with absolute certainty that tissue are dead. It's a blood flow study. And if it sees that blood flow is very low, it assumes the tissue must be dead, even though it may very much be alive. And so if the patient's inside the window, I would tell you that that's over imaging, and you shouldn't even be getting a CTP in those patients. If your organization is doing that, you need to stop. Quite honestly, if I were a patient in your hospital and you did a CTP on me inside the window, I would tell my insurance company not to pay for it because it is absolutely not recommended. Evidence of occlusion on CTA. Look at this, 26% of centers in the US. We led the way here. If you didn't have an occlusion on a CTA, we weren't going to treat you because we didn't believe it was a stroke. Well, that just shows that people don't know how to use the technology that they're imaging patients with. They don't know how to interpret the findings from it, because certainly you can have a small vessel stroke and the CTA will not demonstrate an occlusion. And so you're not treating then patients that you should have been treating. Most common non-standard exclusion criteria selected. Number one, NIH greater than 25. Shame on all of us. These patients have nothing to lose. And in fact, contemporary data show that the SICH rate is not significantly higher in these patients if we are appropriately controlling blood pressure. Altered level of consciousness, again, not good. Antihypertensive continuous infusions. Fortunately, the US did pretty well here, but remember, a continuous IV infusion antihypertensive agent is not an exclusion for giving intravenous alteplase. Age greater than 80, regardless of whether treating within or outside of 4.5 hours. There's still a lot of people that will not treat old folks. And I would tell you that that person, if they are functionally independent, you may have just taken their life away. And interestingly, we found as the number of non-standard made up inclusions and exclusions increased in a hospital, their reported TPA treatment rates decreased. And this was true in all 3 countries. So making up reasons not to treat is not your job, right? What were some of the factors here in the US associated with making up our own criteria? Being a primary stroke center, long door to needle time. So these are people that are taking a long time because they're really trying to find a reason not to treat, and adherence to the 3-hour treatment window. Now, what about minor stroke? Should we treat or not treat minor stroke patients? And there's lots of different definitions for how we define minor stroke, but there are some people in the world that believe that it's totally interpreted by the number on the NIH stroke scale score. And that's why you see things like if the NIH stroke scale score is less than 4, don't treat the patient. But should we allow the number alone to determine whether a patient's disabled? Because that's the key here. Is the patient disabled, right? So let's look at a couple of examples. Here's patient number 1, NIH stroke scale score of 2, and it's made up of a mild lower facial droop and a mild sensory loss on the face. Okay, now you could argue that unless this person was a model, that perhaps that's not disabling and that the patient's going to recover and do just fine. But what about in patient number 2, where the 2 points is made up of a complete homonymous hemianopia from a P2PCA stroke? This patient just lost half of their field of vision in both eyes. They can't drive. They can't go back to work probably. They can't read. They become a danger because they can't see everything in their environment and can fall down and hurt themselves, right? Now, you can't tell me that that person is not disabled, because they clearly are. And that person should be treated. So we need to ask that question, are they disabled, right? And I would tell you that that's very much dependent on each individual person's habits and quality of life, right? If it's a golfer and he's retired, don't assume that that means that he's not disabled. He's not going to play golf anymore with that complete homonymous hemianopia. Now, what about thrombectomy patients? Should they be pre-treated with IV TPA? Well, I want to emphasize that there is no definitive evidence. And in fact, that most of the findings that are out there are largely inconsistent. And in fact, when you really dig in and look closely at the evidence in some of the trials, particularly one that recently came out in China, it exhibited significant bias, right? And so these are things that we have to be really cautious about what we're reading, right? But there is no definitive evidence that IV TPA should be withheld in candidates that are patients for thrombectomy. Now, even if the patient arrives directly to a thrombectomy center, I would say the patient should be treated. And why is that? Well, first of all, even the best interventionalists at times may have a delayed case start time that can't always be predicted. Things happen, right? You think you're ready to go, and then you find out that you're not because you're missing a piece of equipment or there's something else going on with staffing or whatever. Also, even the best interventionalists at times can be challenged by a patient's unique anatomy, which may delay their getting to a clot. Wouldn't you like to have something up there getting to the clot while they're trying to get there? Absolutely. And keep in mind also that hospitals performing thrombectomy do not necessarily achieve the same outcomes reported in clinical trials. Why? Talent varies and aggressiveness can vary. Now, I see this right now in my current Zodiac trial with cases that we believe are thrombectomy cases. Every single person at the hospital is sure that this is going to be a thrombectomy case. So the lead investigator enrolls the patient, and then their interventionalist goes, "No, I don't think I'm going to do it," right? Well, wouldn't you have been awfully upset if you didn't treat that patient? So some interventionalists are not as aggressive as those that worked in the clinical trials. Again, remember, when you are developing a clinical trial, you pick the best possible performers when it comes to something like a procedure, because you want to make sure that you win in that clinical trial. Clinical trials cost millions of dollars, and having a negative clinical trial is an absolute travesty. So the guy at your hospital simply may not be as good or as aggressive. And then also, IV TPA pretreatment does not increase the risk of hemorrhage post-thrombectomy in these patients. So the bottom line is, if the patient meets treatment criteria for thrombolysis, treat the patient, please. Now, let's talk a little bit about symptomatic intracerebral hemorrhage. Now, there's lots of different definitions for SICH, and these originated from different clinical trials. So, for example, in the original NINDSR TPA trial, where this was back again 1991 to 1995, we really didn't know what we should consider a significant hemorrhage. And so we said any blood on the non-contrast CT scan in combination with any clinical deterioration on the NIH stroke scale. So you didn't even have to deteriorate 4 or more points. If you don't believe me, pull the paper. It's right there in the New England Journal of Medicine. Well, despite having such a liberal definition, the SICH rate in that study was only 6.4%. But let's go on. What about the European Cooperative Acute Stroke Study 3, published in 2008? Parenchymal hematoma type 2 in combination with greater than or equal to a 4-point worsening on the NIH stroke scale. So in other words, now we're saying that the hemorrhage has to meet certain criteria to be considered an SICH, because the hemorrhage has to be solely responsible for the worsening on the NIH stroke scale. Now, why is this important? Because let's say I end up having a really big stroke. And let's say that that stroke is this much, half of a brain of ischemic tissue, and there's tiny little spots of blood inside of it. Well, what made the patient worse, the tiny spot of blood or the big ischemic stroke? The stroke, right? And so we need to be very clear, and this is now the definition that we use today for SICH. Keep in mind that ECAS-3 only had an SICH rate of 2.4%. And if you go back and reclassify the NINDSR TPA stroke study CTs, the hemorrhage rate falls down pretty darn sufficiently if you use the new definition. We know now that in the world, SICH rates on average are less than 3%. If you're reporting rates higher than that, it may be that you don't know how to classify SICH. And we'll talk more about that in a moment. But the bottom line is everyone, and especially the people in the emergency department, needs to know how safe you are as a performer. And oftentimes, as a stroke coordinator, and I know when I worked as one, I was guilty of it too, we forget to go down and share this with the emergency department. And so the guys working there simply don't know that TPA is as safe as it is. So please make sure that you share this information with all of the people throughout the house, so that especially in the emergency department, they aren't producing what I like to call mythical rates of hemorrhage. Now, let's understand symptomatic intracerebral hemorrhage, because it's really important that you know this so that you're classifying your patients correctly. And you'll see on the chart here that there's varying degrees of what we call hemorrhagic transformation. Now, when you get your report back from radiology on your CT, it'll say hemorrhagic transformation if there's any little bit of blood on the scan. But that's not how you're going to determine if the patient has an SICH, because as you can see, an HT type 1 is petechial hemorrhage. A more confluent collection of those small petechial hemorrhages is what we call an HT type 2. A PH1 is a frank hematoma, but it doesn't exceed the boundaries of the infarction, and it's not responsible for worsening the patient 4 or more points. But the PH2 is what we use to define symptomatic intracerebral hemorrhage today. And this is consistent with the American Heart Association, get with the guidelines, with Oscar down in Australia, and with SNAP over in the UK. So we're all clear that it's a PH2. Now let's take a look at what these look like. So here's a PH1. And you'll notice, let me see if I can bring up a cursor here. Perfect. Okay. So you'll notice there's a little bit of bleeding. See those little white spots there? That's a PH1 hemorrhagic transformation. Unfortunately, if you're a stroke coordinator and you're hoping that your radiologist is going to say HT1, HT2, PH1, PH2, I'm so sorry to tell you that that is not going to happen, because they don't really understand this very well like our neurologists do. Now, here's a patient with what we would call an HT2, and you can see it right here that there's a little collection of blood there. Here's another HT2. Again, you can see a little bit more organized collection of blood here. Here's a PH1. And again, we can see that there's a frank hematoma, but you see all this dark stuff around it? That is the infarct itself. So what's making the patient worse is look at the size of that infarct. And yeah, there's a little bit of blood tracing down here as well, but this is not causing the patient to worsen 4 or more points. However, this is a PH2. Now, I mean, if you look at this, you can see this patient's got a midline shift. He's got a significant bleed that's extending into the ventricles, all right? So now I would tell you that if you're a stroke coordinator and you're not credentialed to interpret imaging, that your best bet whenever you see a report that says hemorrhagic transformation is to do the following. 1, did the patient worsen 4 or more points? If the answer is yes, then do number 2. And number 2 is have the neurologist tell you if that is a PH2 hemorrhage. You know, for the most part, it's relatively clear, you know, when you look at CTs. Hemorrhages are so obvious that my cat would know that that's a hemorrhage for the most part. Sometimes they're a little bit more subtle, like you see over here, but for the most part, they're pretty darn obvious, right? But still, if you're not somebody that's really comfortable reading images, that's how you should proceed. Now, what did we find out when we did a national study? And this was led by Fern Cudlip and Victoria Swatzel. What did we find out about stroke coordinators and their understanding of SICH? And this is unfortunate. We do have that official definition of a pH2 plus worsening of 4 or more points. However, when we asked stroke coordinators, the majority, 48%, said that the definition was any hemorrhagic transformation on a non-contrast CT or MRI report in combination with any clinical deterioration. So it's clear that this has really not gotten through to all stroke coordinators across the country. In fact, only 17% could correctly define SICH. And among those that adhered to the correct definition, the SICH rates were significantly lower. So if you use the correct definition, you said that it was a median of 3%. If you use the incorrect definition, you said that your hemorrhage rates at your hospital were a median of 6%. So there was a significant difference there. And that means that we have work to do in really getting our stroke coordinators well educated on how to make that classification. Now, let's talk for a moment about controlling blood pressure in patients that have received TPA. And we know that variability of blood pressure is associated with higher rates of SICH, and that steady blood pressure control should be achieved to promote safe drug delivery. Lots of drugs to choose from over here in the US. The traditional choice is labetalol, but note that it is supported by the least amount of evidence, and it's absolutely incapable of producing steady blood pressure control. In fact, I always say that if you're giving labetalol, you have to have what I call a squirt nurse who can stand there and keep injecting the patient over and over, because after about 3 minutes, their blood pressure is going to start going back up again, right? And this isn't good. And so your best choices, and the choices that are more strongly supported by the data, are dihydropyridine calcium channel blocker continuous infusions. And we have two over here, nicardipine and clevidipine. Clevidipine is quickly taking the lead over generic nicardipine because it's found to work better than when we mix generic nicardipine in one of our typical plastic IV bags. But over in Australia, they also have nicardipine. In the UK, I don't think they have either one of those, unfortunately. But here's some other things to check. How does your blood pressure control order read? Does it read if blood pressure exceeds 180/105, treat the patient? That's the most common way they're written. But what that's telling the nurse is that wait until after you have violated the upper limit for blood pressure. And so it really makes no sense at all. We've changed ours to say, if the blood pressure exceeds 170/100, treat the patient. Interrogate your monitors, stored records, if your patient has a true SICH. Go and pull up every blood pressure saved on that monitor, because oftentimes what you find is that what gets recorded in the chart is what the blood pressure was after the nurse treated the patient's blood pressure, not the fact that it might have been 210/120, right, at the time of treatment. So look at that monitored, stored record. We've done this now consistently for the past several years, and 100% of our SICHs, we have found that we had a huge blood pressure violation by nursing that was not addressed for quite some time. And that's really unfortunate. So we need to kind of take responsibility for that. And of course, we need to be staffed appropriately so that we can take care of these patients in a safe manner. I am not going to talk about how quickly we need to treat patients. You've heard that in other ANVC talks. People are shooting to get well below the 30-minute window for treatment. And I know that that's, pretty much the goal that everyone has. And in some cases, getting below 20 minutes or even 15 minutes. Now, what I want to shift to, though, are some critical conversations about treatment. And I asked stroke coordinators around the country to send me some examples of stuff that they knew was dishonest, that was shared with patients or family members trying to make a treatment about whether their loved one should get intravenous TPA. And these are all remarks that came from emergency physicians. Here's the first one, and this came from South Carolina. There's a drug that we can give your wife for stroke, but over 20% bleed in their brains and die. Here's the second one from California. We can give a drug, but we don't like to. We don't recommend it. It is very dangerous, and there's a high likelihood of him getting even worse than he is or even dying. Here's the last one, and this blows me away. Let me put it this way. If my dog had a stroke, I wouldn't give this drug to him. Wow. Wow. So there are practitioners in the emergency department saying crazy things at times to patients. Now, you just looked at the data in terms of TPA treatment and safety, and we'll go through it again in a minute. But notice that there was no 20% bleeding in their brains and dying, right? Now, I want to take a moment then and talk to you about what constitutes informed consent. Because whether we're getting a written informed consent or a verbal informed consent, it has to meet these criteria. So the definition is permission granted and the knowledge of the possible consequences that which is given by a patient, that typically is given by a patient to a doctor for treatment with full knowledge of possible risks and benefits. So that's what is a legal informed consent, whether verbal or written. So consent is an act of reason. And for a consent to be valid, the person giving the consent must be of sufficient mental capacity, must not be coerced or provided with fraudulent information, and must be in possession of all essential information, risks, benefits, and alternatives. Now, when we think about informed consent, it's based on the principles of autonomy or the right to self-governance as well as privacy. Now, this is central to all morally valid decision-making in healthcare and research. So there's 7 criteria that constitute provision of informed consent: competence to understand and to decide, voluntary decision-making, and I've underlined this one, truthful, factual disclosure of material information, recommendation of a plan, comprehension of terms 3 and 4, and decision in favor of a plan and authorization of the plan. So this is what constitutes provision of a legally binding informed consent. So a person either gives consent only if these criteria are met. And if all criteria are met except the person rejects the plan, that person has made what we call an informed refusal. Now, do these statements from South Carolina, California, and Ohio, do these statements constitute someone being provided with truthful disclosure of material information about the risk of intravenous TPA? And I would say, of course they don't. Information disclosure, when we talk to patients, should include things like large clinical trial outcomes. For example, we can talk about the original NINDS RTPA study, which showed back in 1996 when it was approved that the rate of hemorrhage was 6.4%. It also showed that significantly more patients that got TPA achieved a modified Rankin 0-1, were, in other words, functionally independent at 3 months compared to those that received placebo. And that fewer alteplase TPA treated patients died compared to placebo patients. However, the significance level on death what did not meet the threshold of a 0.05 alpha. And that's because there were so few deaths to begin with in the study. We can also tell them if the patient's being treated outside of 3 hours, the ECAS-3 study results, which came out in 2008. Again, SICH rate 2.4. Again, significantly more patients were functionally independent if they got TPA than those that got placebo. And again, there were fewer alteplase deaths than there were in placebo patients. Although again, there were too low a number of death to show a statistically significant difference. And then if we're treating patients that we don't know the time of onset, we can quote the results of the Wake Up study, which was reported in 2018 in the New England Journal of Medicine. SICH rates 2.0. Significantly more alteplase treated TPA patients achieved a modified Rankin 0.1 at 3 months. Now, in this trial, there were more patients with TPA that died than there were placebo patients. However, the death wasn't due to SICH. Now, other things we should talk to them about: limitations in relationship to the subject and whether he or she mirrors the study inclusions that we're using in the trials that we're citing, right? And then the current site treatment volume at your place of practice and your current SICH rates. So these are things that when I'm consenting a patient, that I present to the family. And I can tell you that, again, I've been giving this drug since 1986. I have never had a patient refuse treatment with intravenous alteplase TPA. Now, if it's a non-emergent treatment, generally we require a written informed consent for things, right? But when it's an emergent treatment, we don't necessarily have to have a written informed consent. And so if you're giving intravenous alteplase, you don't need to get that unless you work in a country that insists upon it. But in the standard of care for the United States, it is not necessary. You simply must prove in your documentation that you provided all of those things that I showed you on that list: the factual, truthful information, the risks, the benefits, all of that, right? And that the patient either elected to or elected against. And if it's treatment that's based more on the Wake Up trial, well, you may want to get an informed consent in that case, because that's not uniformly standard of care in the United States at this point of time. Now, when I talk to a patient, one of the things I also add is this: that IV alteplase TPA is a medication that is proven to reduce neurologic disability from stroke at no increased risk of death. And I think that that's a very nice, quick way to kind of cut to the chase and make it clear to patients that this patient's at no greater risk of death when I'm treating within that 4.5-hour window than if I were to withhold that drug. Now, how should you manage unethical messaging if it's happening in your workplace? First of all, I would tell you, and I believe very strongly in this, that we all need to know clinical trial findings like the ones that I have cited here today. ANVC believes very strongly that all clinicians should have that weapon of knowledge up here in our noggins so that we can really improve practice in our workplace for patients, because they deserve nothing less. We need to feel confident professionally and appropriately confronting providers who message inappropriately. So if I were in an emergency department and heard someone say some of the things that I've shown you on this slide, on the previous slides, I would, not in front of the patient, but I would pull the physician out of the room and I would say, I really have a problem with what you just said. It's not factual, it's not truthful, and it's highly misleading and biasing this patient's decision. You know, and I really think we need to be comfortable with that. But again, we can't be comfortable if we don't know the data ourselves. The other thing I would tell you to do is inform your supervisors, because this person has now increased the liability for your organization. And hopefully you've got witnesses that will go with you, because I always think it's good to have a second person who heard the same thing. Otherwise, it becomes a he said, she said. But imagine if clinicians went radical and documented in the medical record in quotations exactly what material was provided. Some of those quotes that I showed you, for example, along with a patient or the next of kin's refusal of treatment. Holy moly, now you're in trouble, right? So let's kind of close this discussion by talking a little bit about litigation involving TPA, because I think that this is important. First of all, the most common people associated with getting sued are emergency physicians, and they like to, unfortunately, be the leaders in discouraging TPA treatment. Their rationale is that they truly believe that risk outweighs benefit. Well, they're not the person taking care of that person after they leave the hospital disabled. They're not the person trying to live their life as a disabled person, right? And I think that that's really concerning. And these are important kind of critical conversations that we need to have with them about this, because they only see that patient for a very brief snapshot. They also tend to be very fearful of litigation if there's an adverse outcome like an SICH. And they either fail to know or believe the evidence supporting treatment and safety. Remember, you can educate people, but that doesn't necessarily remove their attitude towards something, right? And this is kind of where we're stuck with a lot of emergency physicians around the world. So in the paper that I've cited here that Justin Ziven and his colleague Leanne published in the Annals of Emergency Medicine in 2008, and then Hazlitt in 2019, there's two systematic reviews that were conducted 10 years apart on litigation tied to TPA. First of all, the vast majority claim patient injury resulting from failure to treat with TPA. Emergency physicians were the most common defendants, and claims tied to failure to thrombectomy, by the way, are slowly increasing. Now, I want to just close and tell you a little bit about rescue and why we're doing it. And the big question is, can ultrasound enhance or augment TPA treatment? And this is actually a photo that sits on the cover of Circulation that got published in 2000, where we wanted to see what it looked like when patients recanalized an artery after IV TPA. So we were doing continuous transcranial Doppler to see, and all of a sudden you hear this big kind of snap, and then you see the clot break up and flow is restored. Why is this theoretically sound? Because it produces, when you add ultrasound, reversible changes in fibrin. It helps to kind of have streaming of plasma through the thrombus, and more TPA is delivered. So we did a study using handheld TCD probes that we fixated with a crude head frame, and you can see that right here. And we had a consistent angle of inclination pointing to the occlusion. The limitations to this being very generalizable is that TCD is very difficult. And so this was our first study. It was published in 2004. And the bottom line is that we showed that more patients recovered or had complete recanalization or significant reduction in disability if they had the ultrasound aimed at the clot while TPA was running. And there were the similar number of hemorrhages in the brain in each group. Now, since this time, we've looked at other ways that we can do this with different devices that are hands-free, that take away the user dependency. And we've had some limited success, but we have a new device that we're getting ready to test, and I am the principal investigator on this study. And the problem is that when you think about ELVO patients that need thrombectomy, oftentimes they're in primary stroke centers, and it can take 2.5 hours for them to reach a comprehensive stroke center for thrombectomy. So we could give TPA, pop this hands-free device on the patient, press a button and let it work while we're working on getting the patient transferred. So this is going to be the first phase of the project, which is an open label, non-randomized pilot of our new device, which is called Arriva. I'm not allowed to show you a picture of it at this point. And we're doing this in 4 primary stroke centers that 2 will provide the Arriva and TPA, and the other 2 will just provide TPA. All patients will be thrombectomy candidates. All will get transferred to our comprehensive center. And we're going to look at recanalization on the first angiographic run, as well as NIH improvement. So stay tuned. Hopefully I'll have some good information for you in the near future. So I want to close by just saying, remember that your mission as a stroke center is to find reasons to treat, not to find reasons not to treat. And I thank you so much for your attention. I'm happy to take any questions.
Thanks, Anne. Great topic. We do have one question. I know we're a little bit over time, but let's just do this one question and then we'll sign off for the day. This question is, what are your thoughts on doing a CT angio and perfusion inside the window if the intention is to evaluate the patient for LVO, not to assist in a decision for giving thrombolytics?
If the patient's inside the window for any kind of thrombectomy, then the CT, well, first of all, I would tell you all patients should get a non-con followed immediately by a CTA. We can treat while the patient's in getting that study done. But if the patient's inside the window, that patient doesn't need a CTP. And if your interventionalist is insisting upon it, you've got a very conservative interventionalist, again, that does not look like the people in the studies. And so I would tell you that that's something that you probably need to look at. But again, you'd want to have enough firepower in your back pocket that you don't get killed trying to tell an interventionalist how to do his job.
Thanks so much. I actually am going to do one more if you don't mind.
Sure.
Another really relevant question that just popped in was, we're struggling with Joint Commission saying the only allowable sources for abstracting information on symptomatic hemorrhage are brain imaging reports, diagnostic test reports, and radiology reports, which mean that we can no longer rely on the neurologist notes to help with documenting symptomatic hemorrhage. We need radiologists to use ECAS in their notes.
Well, here's the thing, they never will. So that's kind of pie in the sky, would be nice, but it won't happen. But what Joint Commission is telling you is wrong, because you still can, again, if the patient worsened 4 or more points and it says hemorrhagic transformation, you can still call your vascular neurologist and say, does this constitute a PH2 hemorrhage? All right. It doesn't mean that you cannot talk to them about that. It's how you classify it in your database. And they're absolutely wrong if they think that they're going to get radiology to start using HT1, HT2, PH1, PH2. It is not going to happen. And that is absolutely unrealistic. And it's probably a surveyor that does not know practice as well as he or she should.
All right, thank you so much, Anne. We are over time, so thank you everybody for joining today. And as a reminder, this will be recorded and available on our members only page of the amvc.org website. Thank you so much. Everybody have a good afternoon.